Hello again. I'm Dr. Diana Fite, President of the Texas Medical Association. Thank you for joining us tonight for TMA's Tele-Town Hall on COVID-19. This is the fourth COVID-19 Tele-Town Hall hosted by your TMA. We are finishing the process of calling nearly 4,000 OBGYN and MFM physicians across Texas. This will take several minutes. TMA has devoted close to all of our resources for the past 2 months to COVID-19. We want to help you help your patients and your community as we begin to recover from this worldwide pandemic. Earlier this year, your TMA Board of Trustees convened a practice viability work group and a task force on COVID-19. These groups have created multiple resources, including a comprehensive practice viability toolkit, multiple FAQ documents, webinars, and podcasts, and other guidance to help you and your patients and to help you manage your practice. These resources are available at texmed.org/coronavirus. Again, that's texmed.org/coronavirus. Additionally, ACOG has created some valuable resources to help you that are available on the ACOG website. Tonight, I'm joined by Dr. Eugene Toy, ACOG District 11's chair. Welcome, Dr. Toy.
Thank you so much, Dr. Fite. Over the next hour, you will hear tips for improving your practice's financial viability, how to effectively use telemedicine and patient outreach, including messaging to allay patients' fears about returning to the office. We will also cover how to adapt in this COVID-19 environment, including clinical best practices and epidemiological trends. Tonight's panel joining Dr. Fite and myself include Dr. Valerie Smith, a pediatrician and member of TMA's COVID-19 task force, Dr. Kerry Apse, an MFM physician with Baylor College of Medicine, Dr. Joseph Valenti, who is chair of TMA's Practice Viability Workgroup and a member of TMA's Board of Trustees, and Dr. John Thoppil, who is an Austin OBGYN in private practice and the Texas Association of OBGYNs president. Dr. Thoppil will also be moderating questions from our audience tonight. We'll answer your questions periodically throughout the call, so please stay tuned for instructions on how you can ask your questions. We want to answer also some poll questions, and we'll tell you how to reply when that time comes. Even as we all begin the recovery process, we understand that all of us face two major threats right now. The first being the continuing very real threat of this virus that it poses to your patients, your practice, your staff, your families, and to yourself. And equally, the real economic threat of this pandemic and stay-home requirements that have posed so many medical practices and affected all of us throughout Texas. We all know that these are extremely important issues, and we appreciate our doctors joining us on this crucial information tonight. Since TMA is offering continuing medical education for the event, we want to ask a question at the end for CME credit. This is a TMA designated activity for a maximum of 1 hour of AMA PRA Category 1 credit. Physicians should only claim the credit commensurate to the extent of their participation of the activity. The TMA is accredited by the Accreditation Council for Continuing Medical Education to provide CME for physicians. All physicians who remain on the call for at least 53 minutes will automatically receive CME credit. Okay, so this is how you can ask us a question or make a comment during the event. At any time, press the 0 key on your keypad and your phone keypad, and a staff member will greet you. And then please succinctly tell her or him the question and your comment, and soon we'll get to you to ask your question to our experts. At this time, we're going to go to our first polling question, and we want to hear from you. So this is the poll question for tonight is on the financial impact of the pandemic and how it's affected your practice. So please rate the financial impact of COVID-19 on your practice, and you press 1 if it's minimal impact, less than 20% reduction in your practice volume and finances. Press 2 for moderate impact, between 20 to 40% reduction. Press 3 for major impact, 40 to 60% reduction. Press 4 for devastating impact, more than 60% reduction in patient volume or finances. So once again, rating the financial impact of the COVID-19 crisis on your practice. Press 1 for minimal impact, less than 20%. Press 2 for moderate impact, between 20 to 40%. Press 3 for major impact, 40 to 60%. And finally, if you believe that it's had a devastating impact, more than 60% reduction, please press 4. We'll tabulate the results and report them back to you shortly. Now I'd like to introduce our first speaker, pediatrician Dr. Valerie Smith. As we mentioned earlier, Dr. Smith is speaking on behalf of the TMA COVID-19 Task Force, of which she's a member. Dr. Smith will update us on the latest epidemiological trends and the state and federal public health guidance. Dr. Smith, thank you so much for joining us this evening.
Thank you so much, Dr. Toy, and thank you, Dr. Fite, for convening this Tele-Town hall on COVID-19 specifically for obstetricians and gynecologists. And thank you for inviting me to speak to you all as representative of TMA's COVID-19 Task Force. I look forward to learning from my fellow physician presenters on this call, Dr. Eppes, Dr. Valenti, and Dr. Thoppil. I want to start off by giving a general overview of the current status of the pandemic here in Texas. As we know, the Department of State Health Services announced our first case of COVID-19 in Texas on March 4th. And looking at data from today from DSHS's Texas Case Counts dashboard, we now have reported a total of 48,693 cases, 1,347 deaths, and 1,551 hospitalized patients. Compared to last Monday, we've seen an increase of approximately 8,800 cases and 250 deaths over the last week, but we've seen a decrease in hospitalizations of 174. We continue to see new cases daily, with the greatest numbers in our large metropolitan areas, the highest being in Harris and Dallas counties. With increased testing across the state, we recognize that the increases in new cases may be reflective in part of the increased overall testing, and as a result, we are more closely monitoring hospitalization rates. As the governor's reopening plan continues to unfold and we look towards reopening commerce, communities, and our practices, we continue to support doing so in a careful, methodical, and data-driven manner. Also, the COVID-19 Task Force has been working diligently with TMA staff to produce helpful resources to address public health questions of infection prevention and control, testing, treatments, what to do when you have a PPE shortage, and more. These resources are available on TMA's COVID-19 resource page. Personal protective equipment has been a top priority for TMA, and with the fervent pressure from TMA's leadership in collaborative conversations with the governor's office and other state agencies, we really thankfully have been able to ensure a portion of PPE purchased by the states allotted to community physicians. The worldwide supply chain is still critically low and will remain so for the foreseeable future, but TMA continues to work with state partners and local county medical societies to send whatever is obtained to community physicians. As both a member of the COVID-19 Task Force and chair of the Subcommittee on Behavioral Health, I recognize the profound longitudinal impact this pandemic will have on the behavioral health of Texans. Our patients, as well as ourselves and our own families, face fear, anxiety, and uncertainty, and as lives and our practice may be completely changed. The subcommittee continues to develop resources and podcasts to help you and your patients with these threats to behavioral health, as well as to help you as a physician during these unprecedented times. These resources are also available on the COVID resource page. There are 2 points I'd like to emphasize about testing. The first is that there are a number of tests that have been marketed to physicians right now, and the FDA has released multiple warnings of fraudulent tests out on the market with false claims and questionable validity. The FDA, as well as the task force, strongly advise physicians to check the FDA emergency use authorization site to make sure that the company and the test that you are interested in purchasing have at least received FDA approval for an EUA. Second is to remind you that the CDC recommends only viral testing, such as PCR testing, to diagnose acute infection of SARS-CoV-2. Serologic testing or antibody tests are not approved for diagnosis of acute infection, in part because antibody production is not present at detectable levels until several days after symptom onset. For quick resources on COVID-19 testing, please refer to the task force's How to Testing Guide and Testing Frequently Asked Questions, which are both posted on the resource page. And finally, COVID-19 has no doubt taken a priority in our lives and our practices over the past few months. However, as we know, other infectious diseases, illnesses, traumas, and health problems continue to affect our patients and our communities. As a pediatrician, I'm particularly concerned about the drop in well-child visits and vaccination rates. TMA, OBGYNs, and other specialties will need to work hand in hand to push for immunizations for flu and other vaccine-preventable diseases. The task force is poised to help guide members through this new reality of practicing with COVID-19, especially as we look towards the 2021 legislative session to strengthen public health and pandemic preparedness response. So I will stop there with my general public health overview, but please know that the task force hopes to continue to serve as a resource to you. Thank you so much for the opportunity to speak tonight, and I will pass it back to Dr. Toy now. Thank you.
Thank you so much, Dr. Smith, and we really appreciate you joining us to provide this valuable information. We OBGYNs, by the way, we really value pediatricians and neonatologists as a whole. You guys save our hide and save our patients so much of the time. And of course, thank you so much for your service on this task force and helping our Texas physicians during this very challenging time. In just a moment, all of you doctors listening in will be able to have your first opportunity to ask our panel a question. As a reminder, to do so, please press 0 on your phone keypad and then very briefly tell the TMA staff member your question or comment. You can do this right now, in fact, and then listen to the call in the queue, and at the proper time, we'll call on you to ask your question for the experts. But now I have the result of our first poll question. So we asked you, our OBGYN physician audience, to rate the financial impact of COVID-19 on the practice. 38% said moderately severely affected, between 20 to 40% of your volume or finances, 35%, so almost as many major impact, 40 to 60%, and then 14% said devastating, so that would be greater than a 60% reduction, and then only 12% said minimal. So really, another way of saying this is almost 90% of our participants said that there was at least moderate or more financial impact on your practice. So you and our audience, you have our first opportunity to ask a question of our panelists. Dr. Thoppil?
Thank you, Dr. Toy. Yes, now it's time to hear your questions. We have right now actually just one in the queue, so we'd love to get some more people to call in and ask their questions. For those of you not in the queue yet, a reminder to ask a question, please press the 0 key on your phone keypad and brief the TMA staff member on your question or comment. Soon I will call on you to ask your question of our panelists, so please listen for your name when I call on you. Our first caller is Dr. Batra, who has a question about the PPP repayment program. This is actually a pretty specific question, so this one I'll open it up to any panelist who might be an expert on the PPP program. Dr. Batra, please ask your question.
So, like Dr. Smith, I'm actually a pediatrician, and majority of my patients are Medicaid, and we are at least moderately, if not severely, affected by everything. So, I had to let go of a few or furlough a few of our employees, and now after getting the loan, I'm trying to get everybody back, right? And, I have one specific employee who does have genuine medical health issues and is a little bit immunocompromised. And, it's a tough balance, because you want them back, and at the same time, you don't want to jeopardize their health. And at the same time, then it dents us for taking the PPP loan because each FTE counts. And I know it's a specific question, but for us right now, for our practice viability, everything is important. So I don't know if somebody can tell me, is there a thing that we can do in which we can maintain a balance that we don't jeopardize that staff's health, and at the same time we don't get dented for not getting our employee back?
This is Dr. Valenti. I'm the chair of the Practice Viability Committee, and have worked very closely on PPP and EIDL issues. What I would say is if there's any way to have that person working for you from home to assist them in being less exposed while they're immunocompromised, you could still claim them as an FTE and then not have to worry about repaying that part of the PPP. But I would remind you that if you do have to repay that part of the PPP for that employee, you do have quite a long time to pay for it. I think the deferral on the loan is 2 years, and the interest rate's only 1%. So if you can find a way to get them to work from home, fine. If they need to be in the office, you can take all the necessary precautions. And if you really couldn't rehire them at all, the repayment terms are very liberal.
Yeah, I know. And, but for us, and I think it's a lot of doctors like me for Medicaid, a lot of our population is so much not used to telemedicine. And it's a double-edged thing, We are trying our best to call people. So I wish I could just open everything up for telemedicine. We barely have enough to handle, even a few people or not too much people through telemedicine. But, I guess it's a different.
So, those are probably the options you would have to go with, one of those.
Thank you so much.
You're welcome.
Thank you, Dr. Valente. Our next caller would be Dr. Nancy Benford from Austin, Texas. Nancy, go ahead and ask your question.
Yes, thank you so much for letting me ask. This is kind of about pediatricians, but it's also about how we as physicians can affect a better conversation in their community. So Governor Abbott said that we could omit the exam, the pre-sports exam, and allow children to engage in group sports this fall without the exam, which kind of undermines, if sports are safe, a pediatric exam is definitely safe and necessary for the safety of our children in case of cardiac arrhythmias. And then today I heard, not sure it's true, but that they were going to allow softball to even occur as early as this summer when we're still on stage 3 guidelines, which include no groups greater than 10. So I just was asking for commentary and help. Are we trying to lobby some sense into the kind of contradiction of saying you could get out of your fitness exam but allowing the sports to occur? So that's it. Thank you.
Thanks, Dr. Benford. Dr. Smith, I think it's a great question for you.
Yes, so I share your concerns, Dr. Benford, and I will say as pediatricians, we are both our national chapter and our state chapter are participating in a set of advocacy right now focused on the fact that we really can safely see most children in the office and getting those kids in. I think this is an opportunity for TMA and the Texas Pediatric Society to make a statement and work on that. I will also say at the local level, your school district can make their own decision regarding this. So if you have an opportunity to participate in your school health advisory councils or to speak with the chair of your district's school health advisory councils, there's a lot that can be done at the local level to ensure that children are still being seen and screened appropriately.
Thank you. Remember, please continue to call in. Got a question from inside the room that I'll bring up here, and it's sort of related to our first question. It says, what do we need to know about starting telehealth? What would the biggest challenge be? Dr. Valente, I think that might be another one for you since you're going to talk a little bit more about that.
Well, I think the biggest challenge will be equipping both your office with the IT ability to do that and then trying to get the patients on board with it. One of the biggest things I'm going to talk about is how difficult it is to do the telehealth if your patients aren't ready to do it. So we've had a lot of trouble with delays with people thinking they're linking and they're not. Their IT is bad. 6% of Texas doesn't have good internet access at all. And then, of course, people who don't have smartphones, don't have iPads, don't have cameras, that's difficult. Some of these do have to be done on the telephone, and that's still okay to do. And there's even some equal payment for just telephone visits as well. But I think just getting people up on the IT quickly and then getting the patients up to speed on it is one of the biggest challenges.
This is Dr. Thoppil. I'll just put a comment on that too. Just remember that we have relaxations of what the normal rules for telehealth will be. So there's a lot of common platforms that people have on their cell phones that are safe to use right now. One that is a medical one that I've become a big fan on that's beta, but it's rolling out more, is Doximity. If you physicians have the Doximity app, the nice thing about Doximity and their video platform is you text the patient a link right then and there. They click on it, and so you know when they come online. So some of the other ones, you're not always sure if they're going to be on the same time as you. So that's a free option that works very well.
And people will be aware that federal and state waivers have allowed practices to use non-HIPAA compliant platforms like FaceTime and Zoom as needed. That's going to be a limited time, but for the time being, it's going to be okay if we have to do that.
All right. Thank you for each of you who've asked a question. It's all the time we have for questions right now, but we'll answer more questions in a few minutes. Dr. Tori, I understand you have our next presenter.
Yes, thank you so much, John. I'd like to introduce our next speaker, Dr. Kerry Apse, who's an MFM physician at Baylor College of Medicine. Dr. Apse will discuss some of the latest information on the clinical management of obstetrical patients. Dr. Apse, thank you so much for joining us this evening.
Thank you, Dr. Choi. As you mentioned, I work for Baylor in Houston, and as Dr. Smith was mentioning earlier, Harris County is one of the counties with the highest rates. And so I wanted to share some early clinical experience, recognizing that at this point nobody's had this vast experience because things are so new, and sharing clinical lessons and experience and evidence is really important. I think first, one of the things that I wanted to talk about, given many of our ambulatory care settings are opening back up, is how we both clinically care for our patients and appropriately protect our healthcare workers. And this is certainly a very important balance, and I have noticed that folks' ease with coming back into healthcare settings and ambulatory care settings really does balance well with how much we are protecting them. And a lot of this, of course, is PPE, which has been an ongoing challenge. So one of the things that I have learned is really valuable is to know as much as possible, as we have ongoing testing capabilities, what your asymptomatic prevalence rate is, and then appropriately try to protect your healthcare workers in those settings. And a lot of attention has gone in inpatient areas, but really kind of now focusing on what does that also need to look like in ambulatory care settings. And as patients might start coming with slightly increased frequency back into those ambulatory care settings, how do you make sure that you're following infection prevention strategies and also continuing to space out healthcare workers together? A lot of the earlier studies are showing a lot of the areas of virus might actually be in those healthcare settings that aren't direct patient care, where people are taking off of their masks. And so I found that's really important for our healthcare workers to feel comfortable coming back in and taking care of patients. That first and foremost is their protection. The next is, as we're seeing more pregnant women with COVID, there are a few lessons learned and clinical pearls. So we know from early information coming out of New York that in their population, the majority of pregnant women had a mild illness severity. I think it remains to be seen what that will look like for our Texas pregnant women. But knowing as we see women who may require oxygen, often once they become ill and start requiring oxygen, they can become ill very quickly. And so knowing your thresholds to transfer to your ICU, as an example, many of them now are looking at 6 liters of oxygen as potentially being a criteria for escalating the amount of oxygen or the delivery device, and many of them will become ill very quickly. So knowing when you need to transfer out of your facility if you have a pregnant woman requiring oxygen. And then also strategies such as proning, which are certainly things that we are not used to doing with pregnant women, but can be done. I have proned women up to 33 weeks at this point with pretty significant results. So in the non-pregnant literature, we know from ARDS that proning can lead to improved lung recruitment, and that certainly seems to be occurring with COVID. And so practicing ahead of time for proning pregnant women so that you're able to do that for those who may need oxygen, which sometimes can help decrease their oxygen need and potentially delay delivery. I think another one that folks have started using is high-flow oxygen, which is certainly not something typically used in obstetric units. And so becoming familiar with when to use it and the correct settings. It is looked at as an aerosolizing procedure, but it can help prevent mechanical ventilation. Anticoagulation has been another key part to taking care of those who are critically ill with COVID, which obviously has its extra set of considerations for pregnant women, including when you have thrombocytopenia associated with COVID and when you might need to do a delivery, and trying to avoid general anesthesia. So while using anticoagulation might be really important to decrease thromboembolism, it also requires a lot of ongoing communication and sometimes taking off the anticoagulation when clinically appropriate. So those are just a few of the clinical features that we've learned in taking care of pregnant women. I think another really critical point is this current pandemic is really isolating for both our patients and their families. Many hospitals now have significant visitor restrictions, and so a lot of women are in the hospital by themselves or really limited, especially those who might be a PUI or a person under investigation. I myself, unfortunately, had the lesson of having a pregnant woman become very upset and even leave against medical advice because of feeling her family wasn't really adequately involved in the experience. And so I think rethinking the way we do care and involving the family, I'll now call them every day on rounds and try to do that via video as much as possible to update them on how their family members are doing. And also trying to make sure we are adequately keeping moms and babies as much in visual proximity when they can't be in physical proximity. I've had a couple of women who don't even remember having delivered their baby because they were so critically ill and don't see their infant for a prolonged period of time. So really trying to kind of rethink and reprioritize the way we support both women and families, I think goes a long way in this experience. Thank you very much.
Thank you so much, Dr. Apse. That was an outstanding synopsis. And I guess one thing that I'd like to add as well is that our patients are just really, really scared, and they're just not getting good information. And I know that some of our OB patients are going to birthing centers and opting not to deliver at hospitals because they're just afraid. So just really make sure that you message all the time, because we have to fight against some of this irrational fear about how we're really making the environment, both your office as well as the hospital, safe for them. Well, now it's time for the second poll question. Earlier you heard about how much COVID-19 has impacted your practice, and so now we'd like to look at some reasons why. So please indicate the main reason for the financial hit on your practice. Press 1 if it's because of decreased patient volume. Press 2 if it's decreased elective surgeries. Press 3 if it's increased overhead costs like PPE. Press 4 if it's a combination. Or press 5 if it was some other reason that we really didn't list. So once again, the main reason for the financial impact of your practice is 1 for decreased patient volume, 2 for decreased elective surgeries, 3 is increased overhead like PPE, 4 a combination, or 5 if the reason wasn't really mentioned. And we'll tabulate everyone's answers and report the results soon. Dr. Thoppil, it's time for more questions and answers, isn't it?
Yes, Dr. Toy. It's time for all of you to ask more questions. Please, we're doing this for you, so I'm sure there's some questions out there. A reminder to get in the queue, just push 0 on your phone. One of our staffers will take your name and the gist of your question and place you in the queue. Right now, we actually don't have anyone in the queue, so if you want to ask a question, we'll definitely get to yours. We do have some of our studio audience that has questions for us. Dr. Apse, would you say, in a perfect world, what special considerations would a mid-sized hospital be able to provide a COVID-positive pregnant patient?
So I think actually depends not on the size of the hospital. And let me make sure I have your question correct. You think in an ideal world, what kind of care could a mid-sized hospital provide to a COVID-positive patient?
Because not every hospital in our state, of course, will have the resources you do at Baylor. And so I know some of our community physicians want to know, hey, if I'm prepared for this, what type of things should we do in advance before we see any cases?
So I think this is where the level or the planned level of care your hospital is going to be for maternal levels of care goes a long way. Luckily, from that early New York data, about 83% of pregnant women have mild illness, and it's only the remaining that are severe or critically ill. Unfortunately, it can be a little hard to tell who they are. So I think first and foremost, and luckily all of us have the ability to do oxygen, anticoagulation, antibiotics, and monitoring. And for all of those mild cases, I think just being able to closely follow women as an outpatient, because as I didn't mention before, a lot of them can't come physically back in until they're cleared from an infection prevention standpoint. So that's where those telephone or telemedicine encounters are really helpful. But otherwise, I think knowing when you have the capacity to do ICU level care, mechanical ventilation for pregnant women, and when you don't, and if your hospital doesn't, then knowing who you're going to transfer in an emergency and how long it will take to get them there if they need oxygen. And I think those are kind of the main things. There are other treatments like convalescent serum and remdesivir, but honestly they are pretty rare, and I don't think, I think for those higher level hospitals, those really sick women are important, but the majority of hospitals do not need to know how to do that.
Thank you. We have Dr. Eugene Mcclintock calling from Dallas, Texas, with a question about PPE. Dr. Mcclintock, this would probably be a great question for Dr. Smith.
Yes, there's a lot of information out there on what you're supposed to do for a patient under investigation or submitted, but there's really not anything on what kind of PPE we should wear. Just seeing our routine pregnancy follow-ups, GYN problems, people who are not under investigation, what is the appropriate PPE for those routine patients in the office?
So the Texas State Medical Board came out about 2 weeks ago to provide some minimum standard guidance for people seeking routine medical care, which includes if anyone is within 6 feet of each other, that everyone should have a mask of some sort in a healthcare facility. Now that can be a cloth mask the patient brings with them, or a surgical mask that they are provided, and then the provider should also have a surgical mask on. I know in our practice, obviously we cannot mask very young children, so our staff have masks all of the time, and then children who can, and obviously their caregivers are wearing masks during the exam, other than if I need them to remove it for part of that exam. As far as additional PPE recommendations, really those recommendations just fall along the lines of if you're doing a procedure that might be potentially aerosolizing, and in that case to use gloves, gown, and face shield as well. But that is kind of where we are right now with those recommendations.
All right, thank you. Our next question comes from Austin. It's Dr. Malkowski, who has questions about midwife practices. Dr. Toy, you want to field this one for us? Go ahead, Dr. Malkowski.
Sure, go ahead.
Hi there. I was just curious if you have any idea of the impact of the coronavirus on freestanding birthing centers and midwife practices.
Well, we don't have hard data, so we hear from various members in the state, but what we are hearing overall is that first, patients on the whole are just really scared of everything, and especially pregnant women, they're scared because even though the data is showing that our pregnant women, unless they have comorbidities, actually do pretty well, and there's not much evidence, if any, about vertical transmission, but they're just scared. So I have heard anecdotally about increased number of patients opting to deliver at home or at freestanding birthing centers. And in fact, ACOG, through our national office as well as through our state or Texas office, has been sending information to our members and through the community to try to correct these misconceptions. And that's why I think it's so important that all of us, so your hospitals as well as your pediatricians and everyone else, our family physicians who really do a great job caring for our patients, that we message to everyone out there, all of our Texans, that it's really safe for them to come into our offices. It's really important. I know of several cases, in fact, of women who didn't come into for their OB care, and because of that, they developed preeclampsia or bleeding or other complications. And so that's why it's so important. So thank you so much for asking that very important question and for us to message correctly.
Thank you, Dr. Toy. Our next question is from Amarillo. We have Dr. Carrasco, who has a question about miscarriage rates in asymptomatic patients. Go ahead, Dr. Carrasco. This would be a good question for Dr. Apse.
Yes, good evening. Thank you for filling my phone call, and thank you, Dr. Apse, for answering this for me. Here in Amarillo, we've seen a recent rise in our testing positivity for coronavirus, but in the last 2.5 weeks, I've seen 5 miscarriages ranging from 12 to 16 weeks, and all the patients are asking me about being tested for coronavirus, although they are asymptomatic. And my question is, has Houston seen this increase also? And if you have you done any antibody testing to confirm whether coronavirus could have been a causes, although they may have been asymptomatic?
Oh, what an interesting question. I see this question everywhere in so many of the SMFM and ACOG different chat groups because people do seem to be saying anecdotally they're seeing more first and second trimester miscarriages. I have not seen that reported in peer review literature to large amounts, but I'm also going to admit that's really hard because a lot of our first trimester pregnant women have been delaying care for all the reasons Dr. Toy just mentioned, not necessarily because we're medically recommending it, but because of fear, and so they're coming in later. And then a lot of, to speak to Houston, a lot of our places have not done universal testing in our outpatients, only in our inpatients. So I think it's going to be a long time before we know this number, and whether it's the effect of changing or delaying prenatal care or actually coronavirus, I can't tell you in an evidence-based way, but anecdotally I agree we are seeing more adverse pregnancy outcomes right now, it seems.
Thank you. We'll field one last question
Yeah,
because I think this is.
This is Eugene. I just wanted to pipe in. I think the data that we have. So there's some out of China. There's a little bit out of Europe. That really, if there is an increased risk of miscarriage, it's not big. In other words, it's not appreciable. But as Dr. Epps said, I think we're going to have to wait to see exactly what happens. So I guess what I would probably say is our message to everybody out there, especially our patients, is don't freak out and don't get super worried right now. Take care of yourself, and if there is a increase, it doesn't seem like it's highly significant or really substantial. I'm sorry. Go ahead, John.
Thank you, Jane. We got one more question. This is a good one, probably relevant to a lot of people in the room. Dr. Jacqueline Blissett calling from Houston has a question about just taking care of the family. Dr. Blissett, this would be a great question for Dr. Smith.
So my question is really, I'm actually coming back to work from maternity leave. Today is my first day, and my family had expressed a very significant concern, which was, we have all this data that talks about how, I think the last numbers I saw was like 1 in 8 obstetric patients has coronavirus and it may be asymptomatic. And since I'm an obstetrician and gynecologist, I'm curious, should I be worried about when I come home exposing my family? Because my family suggested having like a station in the garage and, wiping down with having wipes, hand sanitizer, like even disrobing everything. Is this a legitimate concern, or it's just hand hygiene enough?
So first, congratulations, and we are so thrilled for you and your family. Going back to work after maternity leave is hard in any circumstance, and this is particularly a difficult time because there's so much uncertainty. There is not another one of these places where I don't have great evidence base for and research base for exactly what to do, except that the practices that we are telling our patients to do to reduce spread are the same things we should be practicing at home. So I think it's not unreasonable to take your scrubs off and to take a shower, but really, good hand washing, touching, washing any surface that might have been exposed before you pick the child up, and then continuing to wash hands well and continuing to reduce, touching the face. And those types of things are really the best things that you can do to keep your baby safe too. And congratulations again.
Thank you, everyone, for these great questions. We have to move on to our next segment. Give us back to Dr. Toy, but we'll have another opportunity for more questions later.
Thank you so much, Dr. Thoppil. And yes, once again, thank you for all of you for asking such insightful questions. Now, let's look at the answers from your second polling question. If you recall, it was asking for the main reason for the financial impact to your practice, and what we found out is that 55% said it was a combination of the various factors. 30% of you said a decreased patient volume. 12% said decrease elective surgery, and then only 1% either increase in the overhead or other. So it sounds like a combination of factors, mainly the decreased patient volume as well. Now, at this point, I'd like to introduce our next presenter, Dr. Joseph Valenti. Dr. Valenti chairs TMA's Practice Viability Workgroup, and he also is a member of TMA's Board of Trustees. And by the way, this is a time where I really want to encourage our OBGYNs especially that if you're not a member of TMA, and I know this is a tough time financially, but TMA does so many things for us, and behind the scenes and actively, they really go to bat for all of us. But anyway, Dr. Valenti is going to share some tips about how to effectively use telemedicine in an OBGYN practice. Dr. Valenti, thank you so much for joining us this evening.
Thank you, Dr. Toy. I am a private practice OBGYN in Denton and Frisco, and I want to go over some of the finer points of telehealth and some of the things that have worked in my practice as we were very early adopters of telehealth. First, I'd like to talk about a little bit about the types of visits that are appropriate. Breastfeeding support, contraceptive counseling. We have done both pre- and post-operative visits by telehealth, even having people show us wounds with their cameras. Urinary tract infections, medication refills, both birth control and hormonal, Gardasil counseling, and then screenings for depression, mental health, domestic and interpersonal violence, which, as we all know, is suspected to be going up at this time, but unreported, and then substance abuse, including alcohol and tobacco. But I would also tell you that one of the things we've learned is to ask every patient about COVID as well. Are they isolating? And that is a very good time to dispel myths and rumors like, my mask may cause carbon dioxide poisoning, therefore I'm not going to wear it. These are good times to stop that sort of foolishness and bring people along in what is evidence-based. Another thing we've been looking at is we all know with global payments with not Medicare and TRICARE, but with commercial insurance, we spread out some of those patients, and maybe we'll change them from 13 visits to 9 or 10 visits, which is still perfectly fine for a lot of patients, especially our low-risk patients. We even did some remote monitoring of patients and then having patients drive up to our portico share and having people mask and gown and listening to heart tones and things like that. So we've done all kinds of things to try to give our patients another way to get hold of us. One thing I did mention earlier that I'll repeat, you have to make sure that your patients have the hardware and software before the visit, and that puts some pressure on your staffs to make sure that people are set to have that kind of visit. You'll be very frustrated if the visits take longer than a standard visit because of connectivity issues. Of course, you still can get reimbursed for telephone calls as well, but it's nice to do the telehealth visit. I think a lot of patients really appreciate the ability to do that. A reminder that the payments for telehealth are relying on either medical decision-making or time, but the time is the entire time for the visit. And the actual terminology is all the time associated with that E&M. So just be aware of that when you're billing. I did mention earlier that we have a relaxation currently of federal and state waivers to HIPAA-compliant platforms. So people that need to use FaceTime and Zoom for a limited time, we're going to be able to do that. A reminder about billing, state and federal waivers require a lot of health plans to currently pay the same amount for a telemedicine visit as they do for an in-person exam, even an audio-only exam. And payment parity applies to Medicare, Medicaid, and state-regulated plans. But a reminder that ERISA plans, or the healthcare plans that are self-funded, which make up about 42% of the Texas insurance market, are not subject to the parity rules. Some do, some don't. And a reminder, too, that Blue Cross Blue Shield is heavily invested with ERISA-type plans, so be aware of that. There is a site restriction waiver. So even when you're seeing patients from home, which I did for a number of weeks, on telehealth on my laptop, you're still billing as the site of service as the office. So you still have to do that even if you're seeing people from home. As you conduct visits, you might want to start thinking about how it makes sense to continue telehealth for your patients in your practice. It'll work for some practices, for others it will not. A reminder, too, that some of the waivers are set to expire at the end of May, But of course, TMA and a lot of other groups are pushing to extend those waivers. I think overall, telehealth can be really helpful to a practice. We have to be mindful of the limits on what we can do. But I think for a lot of people, it really is useful. A reminder that a lot of our patients, though, do not have broadband, and that's been documented to be up to 6% of Texas. A reminder, too, that we have a lot of resources on the TMA page for physicians adopting and adapting to telehealth, and that's at www.texmed.org/telemedicine. Additionally, I'd be remiss if I didn't mention that our Practice Viability Resource Group has been working diligently over the last 2 months to publish as much information as possible about helping you on your road to recovery. And that information can be found at www.texmed.org/practice viability. With that, I thank you for your attention tonight, and I turn it back over to Dr. Ppe.
Thank you so much, Joe. We really appreciate your advice and insights, and that was fantastic. I'd like to just give 2 other small points. One is that a lot of the legal obligations are exempt during this time of COVID, but as you can imagine, 5-10 years from now, people are going to forget. So just put a smart phrase and make sure that you put during this time until it ends, that this is during the COVID crisis. So in case
excellent point.
HIPAA or other kind of things. And the other thing that I would say is, as Dr. Valenti was saying, that a telephone call, my experience is that patients just don't see that as comprehensive as a visit. So really having the video of some kind is good to do. So thank you so much. We'd like to also remind our participants that you can find practice viability and resources again at texmed.org/coronavirus. And then let's move on to and then our next polling question. We know that this situation has been really stressful for everyone, and that's part of the main reason we're having this town hall, by the way. Our next poll question shifts gears and really is focused on physician wellness. So we want to know about your personal stress level due to COVID. We may not have enough numbers on the telephone pad, actually, to be depending on your stress level, but we have 4 choices. 1 for mildly stressful, 2 if you believe it's moderately stressful, press 3 if it's severely stressful, or press 4 if it's unbearable. Once again, your personal stress level from COVID-19. 1, mildly stressful, 2, moderately stressful, 3, severely stressful, and 4 if it's just unbearable. And then we'll share the answers with you in just a bit. Now, we're going to move on to our last speaker for tonight, Dr. John Thoppil. He's been moderating our question and answer sessions tonight, and now he's going to share some of his own best practices for practice recovery. He is the Texas Association of OBGYNs president, as well as an OBGYN in Austin. Dr. Thoppil, thank you so much for moderating our Q&A tonight and for presenting.
Thank you so much, Dr. Toy. I started private practice as a solo doc, 6 years ago, and now we're 7 providers, so I've faced a lot of the same challenges, the people on this call are facing. I'll just walk through what we did to try to survive this time. Obviously, revenue is down. A big part of that was we were limiting patients who came in the door, as many of you are doing. We were deferring well checks. We were putting off, older patients that didn't have to come in, calling in birth control. All those things, it's good for, it's the right medicine, but unfortunately it took a big financial hit because that's a big chunk of what we see. And so, during that time, what we try to do is really focused on AR. There's always insurance denials, et cetera, that sometimes just get further down the list of work to be done since there's new claims. I think it's really important to go back and work on those claims, and there is a little bit of more time for your staff to do those things. The other big thing to look at is your expenses. For many practices, rent is a meaningful portion of their monthly spend. Throughout the country, across businesses, most landlords are working with tenants in some form or fashion. In the best case, in one of my offices, we got a 2-month rent abatement. Basically, it's a deferment with an extension of 2 months at the end of the lease. So I think it's very reasonable for people to ask for those type of things. And personally, that's what I think that's the best thing to ask for, is really a deferment with an extension for 2 months. In another one of my office locations, they at least let us just pay the triple net and put off the rent and break that over no interest over a few months. So that helps with bringing down some of those costs. And then just looking at line items, just like in personal expense, it's very easy to start having some monthly sort of things that come across that you're not really even sure what they are. I would look at every recurring expense to see if all those are necessary, especially during this time. The CARES Act provided some really fantastic benefits, and I hope everybody was able to apply to at least some portion of it. We talked a little bit about the PPP program. I think that's the best part of this. The PPP program is continuing to have new guidance come out. The first round of money obviously went away very quickly. The second round of money, there's still money available. 75% of that has to go toward payroll, and so yes, you have to bring your staff back, but in a medical practice, payroll is obviously one of our bigger expenses. So I think that was something that most people can get advantage of. The other thing that if you're not able to qualify for the PPP program, businesses can defer their portion of payroll taxes. So that basically is about 7.5%, and defer those into late 21 or 22. And so deferring some of that expense until when revenue comes back really will help from a cash flow standpoint. Finally, from a furlough standpoint, people are cutting expense, by again, if you're going to get PPP and you need to furlough employees. A lot of people are trying to keep their staff on, but just had to cut hours. One of the benefits of all these acts that have passed is that Texas is one of the states that have allowed for a shared work program. And it's sort of an alternative to a layoff because they will get some unemployment benefits to make up the difference of what you were not able to cover. And so it really is an opportunity for the practice to win and the patient and your employees, or for many of us family, to not be hurt by any of this. I think one other big thing to consider from a legislation standpoint is the Families First Coronavirus Prevention Act states that anybody who is enrolled in Medicaid on or after March 18th, including women who otherwise would have lost coverage in the postpartum period, the 60 days for pregnancy Medicaid, cannot be disenrolled until this federal health emergency is over. So many patients are going to be losing their employer-covered insurance. We might see more government-funded patients, and so I think that's an important thing to think about as it go forward. Once things are starting to open up, and I don't know what you guys are seeing in your practice, but in the last 2 weeks we've sort of started opening things back up. Obviously, the governor gave more leniency to doing cases, and so we started doing our in-office cases, and at that point we started bringing back more patients into our office. So we're kind of in a hybrid between where we were. When this first started, we're probably seeing about 30% of the volume we normally do. Now we're probably seeing 80% of the volume. We're seeing some of the healthier well women checks back. An important part of that is communicating with your patients what you're doing differently from your flow standpoint. In a perfect world, we'd have a sick room and a well room like pediatricians do, but most of us in private practice, there's no logistics for that. So the best way to do that is minimize wait times in your exam room, bring people back, and constantly check. So we want to communicate that to our patients so that they know it's safe to come back. One other thing, when you start seeing all these patients now and all these deferred well woman exams, realize what happens next year, right? One, we have to accommodate them now. Do you want to do extra hours? Do you want to do maybe a Saturday clinic that helps catch up, right? Because you have your space during that time. But then also think about how your reminder system is for next year. You don't want to have all your well woman exams, for the last 3 months, last quarter, all be scheduled in May for next year. So think about how you might have a system to kind of spread them out for next year also. The TMA has a fantastic practice viability toolkit at www.texmed.org/coronavirus. That's a great place to go look for more information. And I know, we could talk about this forever, but we're sort of on limited time. Thank you, Dr. Toy, for giving me the opportunity to speak.
Thank you so much, John, and thank you for all the wonderful things that you have shared and also what you're doing in your practice. Now, time for the results of our third poll question. Earlier, we asked everybody about your personal stress level due to COVID-19, and really that's the main reason we really wanted to have this call tonight, is just for all of you to know that we are here for you and you're not alone. 43% of you said moderate stress, 28% said severe stress, 25% said mild, and 3% said unbearable. So right now I'd like to talk to the 45% that said either moderate or unbearable, or the 75% that said moderate, severe, or unbearable. And that is that this is a really, really tough time, and physician burnout and suicide rates are ever increasing, and especially during this crisis. So if this is a time where you're about to break. Take time to talk to somebody. We have help for you, and you're not alone in this crisis. So I really want to make sure that we let you know about that. Okay, so now at this point, then we are going back to Dr. Thoppil for some more questions.
Thank you. Now is your final opportunity tonight to ask questions of our panelists. If you're not in the queue, press 0 and we'll get you there. And I'll call you by name. Our first question is from Dr. Plenty in wonderful Katy, Texas. This is a good question for our pediatrician, Dr. Smith. Go ahead, Dr. Plenty.
Hi, and thanks for taking my question, and thanks for having this call tonight. I was wondering, with the increase of asymptomatic OB patients, when they come in and deliver and they're positive, how long after they go home should they be separated from their baby? What are we telling them if they're asymptomatic versus if they had to get treatment at some point in time?
So I will also say that I would love to hear Dr. Apse thoughts on this. Thankfully, in my corner of the state, we have not had a huge spike in cases, and so I have yet to take care of a newborn with an asymptomatic COVID-positive mom. But generally, the recommendation from the American Academy of Pediatrics right now is to try to isolate mom and baby with as limited contact as possible for 14 days, because if they're asymptomatic, we don't know where in the course of the illness or how long they may be contagious. That can include mom pumping. That can include also, if not possible, mom to breastfeed with a mask on and then, having washed her hands, and then continuing to have somebody else do the primary caregiving. I know for many moms that is really not a terribly realistic option right now, and so that is a very stressful piece for new moms right now. It kind of goes counter to everything I know about pediatrics to tell a mom to stay away from her newborn. I welcome any thoughts from Dr. Apse on that as well.
I think that was a really insightful way to put it. I think there's a kind of gold standard and idealized way to answer it. But from what I've learned, I think if you make the recommendations from the CDC or the AAP, then it's also important to see, is that feasible in the context of who's in their home, whether or not they have any healthy caregivers. I have learned to ask a lot more detailed questions about who's in your home and what their symptoms are than I ever did before. And many of our women are going home to households where there is not a healthy caregiver. And so I think then doing the next best strategy to minimize exposure is really important. And I think I would agree exactly with what Dr. Smith just said.
Thank you. Our next caller is Dr. Paul Tuller from Amarillo, Potter, Texas. Dr. Tuller, go ahead and ask your question, please.
Yes, thank you. Center for Disease Control has been very good about giving employers guidance in the country for when to reopen and how to take care of their employees. But for employees' standpoint, if the obstetric provider is himself or herself over 65, diabetic, and hypertensive, when is a good time to return to direct patient care?
Dr. Tori, do you want to field that one for us?
Sure. This is such a tough question, and I get this actually quite a bit at the time. I had an in-person meeting. We don't have one of those very often, and one person was like way in the corner and had probably like 2 masks on, and I found out later on that this person was high risk. So I think has to be very much individualized. And I think it depends also on the community, where you are, and what the prevalence rates are. So I'll answer it in 2 different ways. One is based on the data and what you have in front of you. In other words, what is the prevalence? How many positive patients are being seen in your particular setting? Remember that it's the pre-symptomatic and asymptomatic patients who are most infectious, so that becomes difficult. Second of all, the issue is how much risk individually a person can bear based on that data. And then on the other side of it is just your personal beliefs as you look into this, because at the same time as we have this COVID crisis, there's a lot of other things that can kill us as well that we're just not paying attention to because there's not reports on that. So I would personally say that right now in most parts of Texas, the prevalence of COVID seems to be decreasing in most areas. People are becoming much more aware of how the virus is spread and what to do, and just really, really careful hand washing and just paying attention overall, I think is so key. But thank you for bringing up that point, and that we have to take care of ourselves. So thank you.
All right, we have time for one more question. This question comes from Dr. Mcclintock in Dallas, Texas. Question about insurance as coverage. It's a great question for Dr. Valente.
Yes, I've seen on the TMA website, we're talking about getting into the telehealth, but on the TMA website it has insurance companies and that they plan on no longer covering telehealth at the same rate. Some of them like as early as early June. I didn't know if you guys were aware of where that is. Is there hope for that to be extended, or what the status of that is?
That's a really good question. I think with regard to the federal plans, there's a pretty big push on to look at it as a continuous thing. And certainly for other groups, even non-OBGYNs, especially psychiatrists and other people who work in rural areas, it's a real benefit to have that sort of thing going on. I have heard that Humana may try to continue it. Again, we're having a lot of trouble with Blue Cross Blue Shield because of all the ERISA plans that they have, and most of the people that they're contracting with, the employers don't want to continue to pay for this benefit. So TMA will, as a group, advocate for this because we think it's really helpful, especially in areas that don't have good access to care. I think the problem is, though, it's going to be pretty variable per company. Oftentimes the companies will follow what Medicare does, but that's usually following on the downside and not on the upside. So you have a commitment from us as your representatives that we will continue to work with the liaisons we have with insurance to get not only telehealth covered, but also covered at a parity with an in-office visit, because the medical decision-making and the time may be the same or even more.
Thank you. I'm afraid that's all the time we have for your questions tonight. If you're unable to ask your question, please email us at knowledge@texmed.org, and one of the staff members of Knowledge Center will respond in a couple of days. Dr. Tori, back to you.
Thank you. And now I need to ask everyone the final poll question for the CME evaluation question. The question is, which step will you take as a result of participating in today's Tele-Town Hall event? Press 1 if you'll apply new knowledge in your practice in response to the pandemic's impact in your practice. Press 2 if you use the information learned to modify any practice operation elements. And then press 3 if you will change the way you monitor your financial viability. Press 4 if you'll do more than one of the above. Press 5 if you will do none of the above. Once again, press 1 if you apply new information to your practice, so in other words, more clinical. Press 2 if it's going to be the operations elements of your practice. Press 3 if it's the financial viability of your practice. And then 4 if it's more than one. And press 5 if it's none of the above. Thank you to everyone for participating tonight. We hope that this information was helpful to you, your practice, your patients, especially to you as an individual, for your psychological, your mental, and your physical well-being. Dr. Fite, I now hand it back to you to conclude tonight's event. Thank you so much for being here for TMA's participation in this event.
Thank you, Dr. Toy. We're glad we could present this meeting. We are near the end of our time. We want to thank everyone who joined us this evening. We hope this TMA service has been beneficial to you. Our goal is to help you respond to the serious public health threats and to empower you to keep your medical practice viable now and in the future. Remember to visit www.texmed.org/coronavirus for practical tips and tools. That's texmed.org/coronavirus. If you were not able to ask a question of our panelists tonight but wanted to, Please email TMA anytime at knowledge@texmed.org, and TMA staff will reply in the coming days. Physicians who remained on the call for at least 53 minutes will automatically receive CME credit. You do not need to do anything to receive that credit. Again, we have your number and a log of how long everyone stayed on the call, so if you listen for at least 53 minutes, you will receive CME credit. I want to give special thanks to our expert presenters this evening, Dr. Valerie Smith, Dr. Joseph Valente, Dr. Catherine or Kerry Apse, and Dr. John Thoppil. I also want to thank Dr. Eugene Toy for helping to lead this call. Here again is our TMA's COVID-19 resource webpage for more information about practicing during this pandemic, texmed.org/coronavirus. Once again, I'm Dr. Diana Fite, TMA President. Thank you again for joining this TMA Texas OB-GYNs Tele-Town Hall on COVID-19. Good night.